Hi everybody, welcome to part 5 of adult electrocardiographs, and this deals with uncommon ECGs. As I mentioned previously, look, these Learnshops, all my Learnshops are essentially for you, and this one is for nurses that specifically monitor adult cardiac rhythms, but it can be any healthcare provider. So the learning objectives for this session are to look at uncommon arrhythmias and dysrhythmias, which could be sinus, atrial, junctional or ventricular. Let's review knowledge again for the last time. Which of the following is the normal pacemaker of the heart? A, the SA node, B, the AV node, C, the His node, or D, the Purkinje fibers? The answer is A, the sinoatrial node. Which of the following are components of the conduction system of the heart? A, the SA node, B, AV node and His node, C, Purkinje fibers, or is it all of them? And the answer is all of the above. Which of the following statements best represents the P wave? Is it A, ventricular depolarization, B, atrial repolarization, C, ventricular repolarization, or D, atrial repolarization? Well, the P wave is represented by atrial depolarization on the ECG. Which of the following statements relates to the sympathetic nervous system? A, it increases the heart rate, B, increases conduction speed, C, increases contractility, or is it all of the above? D. The correct answer is all of the above. Which of the following statements about the normal heart rate is correct then? A, 60 to 100 for an adult, B, 50 to 80 for a newborn infant, C, 35 to 85 for an infant, or D, all of the above? Well, the correct answer is A, 60 to 100 beats per minute. Which of the following relates to the parasympathetic nervous system? A, it slows conduction of the SA node, slows conduction of the AV node, slows the heart rate, or all of the above? Well, it does all of the above. Which of the following are standard ECG leads? A, 1, 2, 3, B, AVR, AVL, AVF, C, the unipolar and bipolar, D, all of the above? The correct answer is all of the above. Which of the following relates to sinus tachycardia? Is it due to parasympathetic nervous system stimulation? Does it have a heart rate of 40 beats per minute? Does it decrease myocardial oxygen demands? Or is it none of the above? Well, it's none of the above. Which of the following connect to atrial fibrillation? A, is chaotic electrical activity, B, has a rapid irregular rate, C, has no P waves, D, all of the above? The correct answer is all of the above. Which of the following correlates to premature ventricular complexes, ectopics, contractions, PVCs? A, they originate in the ventricles. They're wide in appearance. They have an abnormally shaped T wave. Is it all of the above? The correct answer is yes, it's all of the above. Can you name the following ECG anomaly now? Well, it's premature ventricular complexes, and these are couplet. In actual fact, they're premature ventricular complexes, which are unifocal and couplet. Can you name the following ECG anomaly? Well, it's a rapid heart rate. This is a supraventricular tachycardia. What about this ECG anomaly? This is coarse ventricular fibrillation. Can you name this ECG anomaly? This is asystole. What about this concluding ECG anomaly? This is atrial fibrillation with a controlled ventricular response. Some people call it slow AF. Now let's review some of the uncommon arrhythmias or dysrhythmias that could occur in adults. And we're going to review sinus dysrhythmias, atrial dysrhythmias, junctional dysrhythmias, and some of the ventricular dysrhythmias. And remember, these are not by any means complete. These are the more commonly uncommon. This is sinus node dysfunction. And sinus node dysfunction was a term that was introduced many years ago in place of sick sinus syndrome, which can also reflect the Tachycardia-Bradycardia syndrome. They all basically mean the same thing. The sinus node isn't working properly for some reason. And this can be associated with medication toxicity and cardiac surgery for a number of different procedures that can be done on open heart or open chest surgery. And this results in a rhythm that can sometimes be slow, have periods of sinus arrest, sinus pause, bradycardia, tachycardia, junctional rhythm, sometimes Idio Ventricular, etc. But it just results in an irregular heart rhythm. Then you've got atrial tachycardia. And atrial tachycardia is essentially a very fast supraventricular rhythm. And it's demonstrating abnormal P waves, but still a narrow QRS complex. But sometimes, which I haven't included here, the QRS complexes can be wide and attempt to mislead you because of aberrant or abnormal conduction. But the heart rate is typically greater than 160 beats per minute. This is PAT, paroxysmal atrial tachycardia. And the paroxysm basically is the initiation of a very, very fast heart rhythm, which is typically greater than 300 beats per minute. And this typically has a narrow QRS complex. And it can be associated with accessory pathways such as the bundle of Kent, James fibers, Mayheim fibers, and Kent bundle is associated with Wolff-Parkinson-White syndrome, James fibers with Langowan-Levine syndrome, and the Mayheim fibers with AV reentry nodal tachycardia, which can be related to heart disease, which can be structural, congenital, can be related to infections, electrolyte imbalances such as hypomagnesemia, or it can be related to digoxin toxicity and other cardiac medications. When it comes to junctional AV nodal dysrhythmias, there are three common AV nodal pacemaker sites: superior, medial, and inferior. And if the pacemaker is located at the superior side of the AV node, then the monitoring electrode, lead 2, will see an inverted P wave before a narrow QRS complex which is less than 0.12 seconds. If the pacemaker site is in the medial AV node, then the P wave will be hidden in a narrow QRS complex, which again is less than 0.12 seconds. If the pacemaker is located at the bottom portion of the AV node, close to the His bundle, then you'll have an inverted P wave, but this will be after a narrow QRS complex, which is typically less than 0.12 seconds. So when we look at the three common junctional pacemakers, these are the rhythms that you would see: superior, inverted P wave before a narrow QRS complex. medial hidden P wave within a narrow QRS complex. Inferior P wave follows a narrow QRS complex and it will be negative. So when we look at junctional or nodal dysrhythmias, we'll be looking at premature junctional complexes, junctional rhythms, accelerated junctional rhythms, and junctional tachycardia. And these can be associated normally with physical activity, excitement, caffeine, cigarette smoking. Really, that's premature junctional complexes. Junctional rhythms, accelerated junctional rhythms, and junctional tachycardia are typically related to structural heart disease, or hypoxemia, or electrolyte abnormalities such as hyper or hypokalemia, acid-base anomalies, metabolic acidosis, hypothyroidism related to thyroid disease, and medication toxicity, which could include digoxin. When we look at a premature junctional complex, it's similar to a premature atrial complex. It's similar to a premature ventricular complex. However, this originates at the junction. So this is typically occurring within a sinus rhythm, and it makes the rhythm irregular. These complexes are premature, therefore they're early, and as I indicated previously, there can be an inverted P wave before the QRS complex, after the QRS complex, or no P wave hidden in the QRS complex, which the one that we can see in this rhythm strip is hidden. When we look at junctional rhythm, this can occur because of failure of the SA node, as we said, and typically this rate will be between 40 and 60 beats per minute. This is a slow, regular rhythm, and again, it can have an inverted P wave before or after the narrow QRS complex, or it can have no P wave, which is hidden in the QRS complex. The QRS complex is typically less than 0.12 seconds, narrow, and this is typically related to surgery, heart surgery, or it can be related to acquired heart disease, because we all get older and we develop cardiovascular disease, or it can be related to medication toxicity. The important thing to note is that it's a bradycardia and it doesn't have a P wave, and if it does have a P wave, it's inverted before or after. Then you've got accelerated junctional rhythm, and for some reason the junctional rhythm becomes faster, accelerated, but it doesn't exceed 100. Because if it exceeds 100, then it becomes a tachycardia. So accelerated junctional rhythm is a faster regular rhythm with a heart rate between 60 and 100 beats per minute. It can have no P wave hidden, as it's demonstrated in the rhythm that you're looking at now, or it can be negative in front or after a narrow QRS complex. And again, this is typically related to different types of surgery or failure of the SA node related to aging or medication toxicity. Then you've got a junctional tachycardia. And junctional tachycardia is faster than 100. It's regular, and it has no P wave if it's hidden, medial, pacemaker, before inverted, narrow QRS, superior pacemaker, or after a narrow QRS complex, inferior pacemaker. But it typically has a narrow QRS complex which is less than 0.12 seconds. And again, related to certain types of cardiac surgery, medication toxicity, or just getting older. Uncommon though. When we move on to ventricular dysrhythmias, the uncommon ones are basically Idio Ventricular rhythm and accelerated Idio Ventricular rhythms. And these are associated with structural heart disease, congenital heart disease, ischemic heart disease, post certain types of cardiac surgery, hypoxemia, severe acid-base derangements, hypokalemia and hyperkalemia, hypomagnesemia, and long QT syndrome. When we look at Idio Ventricular rhythm, this is a bradycardia. And it's a very slow regular rhythm at a rate between 20 and 40 beats per minute. And as we said, this could occur if the SA node fails and the AV node fails as well, which means you've got some really pathological situation occurring in your conduction system, your heart. The QRS complex is typically wide, wider than 0.12 seconds, and there's no P wave. And as I said, this could be associated with structural heart disease, acquired heart disease because you're getting older, after cardiac surgery, severe hypoxemia, electrolyte anomalies, and acid-base disturbances. Accelerated idioventricular rhythm was just a variant. And even though it's a little bit faster, between 40 and 100 beats per minute, there's no real understanding as to why this could possibly occur. But this is a faster, regular rhythm, which is pathological. The QRS complex is wider than 0.12 seconds, and there's no associated P wave. And it's associated with structural heart disease, acquired heart disease, post-cardiac surgery, again hypoxemia, electrolyte anomalies such as hyper or hypokalemia, and acid-base disturbances, metabolic acidosis in particular. So let's revise now. And this is the final session that we'll do revision, so have a go. This is a 24-year-old male complaining of palpitations. What do you think the rhythm is? Look at it completely, not just the anomaly. This is a sinus rhythm with unifocal couplet premature ventricular complexes. You've got a 20-year-old female and she's asleep in an observation ward somewhere in the hospital. You're observing it because you're the telemetry nurse. This is sinus rhythm. You've got a 32-year-old male receiving bronchodilator therapy for his chronic lung situation, which is asthma. The rhythm is a little bit fast, approximately 150 beats per minute. This is a sinus tachycardia. Now you've got a 19-year-old male who's receiving conscious sedation in a clinic. Maybe he's having a dental extraction. This is a heart rate approximately 70 beats per minute. There's a sinus rhythm with unifocal premature ventricular complexes. He may need some oxygen. This is a 15-year-old adolescent asleep following treatment during the day, and he's just being recovered before he goes home. This is sinus arrhythmia. A 16-year-old female, she's very anxious and very stressed. She's come into your emergency department. She's hyperventilating. And you connect her up to the ECG monitor and you see this rhythm, which is approximately 150 beats per minute. This is sinus tachycardia. Now you've got a 45-year-old male who's complaining of central crushing chest pain. You've got a very irregular rhythm. What do you think? This is ventricular bigeminy, because you've got a normal and you've got an abnormal beat, and the abnormal beat is a PVC, and they're working together. This is not couplet, this is ventricular bigeminy. Bigeminy means basically two together. And where is the Gemini, the origin? It's coming from the ventricle. Ventricular bigeminy. Now you've got a 76-year-old woman who's severely malnourished. She's hypokalemic with a potassium of 2.8, and she's having a lot of extra beats, and they're wide complex. You're having initially couplet unifocal PVCs, and then she goes into ventricular tachycardia, monomorphic, at a rate of approximately 150 beats per minute. Now you've got a 56-year-old male who's got severe hypoxemia and severe acid-base derangements. He's hypoxic with a metabolic acidosis, and he's in a bradycardia. You've got to decide what sort of bradycardia. There are no visible P waves. The rate's approximately 45 to 50. No visible P waves, as I said. This is a profound bradycardia, which is a junctional rhythm. Pacemaker is medial, AV node. Now you've got a 93-year-old male who suddenly collapsed at home. His wife called the emergency medical services, and when they arrived, they put him onto ECG monitoring, and this is the rhythm that he's in, a bradycardia. What sort of bradycardia? The rate is approximately 30 beats per minute if you use the times 10 method. It's wide complex, no P waves. It's a concern. He's not responding. This is a profound bradycardia, but it's an Idio Ventricular rhythm. Another severely malnourished 72-year-old female. Look at the rhythm. Look at the unifocal PVC landing right in the middle of that T wave, the normal beat. This is sinus rhythm with R on T PVCs, which could deteriorate into ventricular tachycardia, which could be occurring as a result of hypomagnesemia because she's malnourished. Now you've got a 22-year-old female with anorexia nervosa. And that anorexia nervosa can result in hypomagnesemia, hypocalcemia, hypokalemia because of malnourishment. She's having PVCs within a rhythm. Look closely. This is ventricular bigeminy PVCs. Have a look. Normal beat, abnormal beat. Normal beat, abnormal beat. But some of the PVCs are multifocal as well. Some are negative and some are positive. But she's having PVCs. That's the important thing. Ventricular bigeminy PVCs. You can just say premature ventricular complexes. 52-year-old male complained of severe chest pain and suddenly he collapsed. With the emergency services department, they connected him to the monitor and they looked at this rhythm. He's unresponsive. This is coarse ventricular fibrillation. Code blue. Now you've got a 54-year-old female who, after 1 hour of resuscitation, the doctor said, let's just stop and have a look at what the rhythm is. This is the rhythm. Or this is not the rhythm. This is asystole. So, thanks again for following this review. This is part 5, the final component of these adult ECG Learnshops. And consider other YouTube Learnshops. And I don't often say this here now, but if you think that these are of any value, of any interest, please let other people know about them. Thanks a lot, and I'll see you in some of the other Learnshops.